All right, esteemed colleagues, let's dive into a really critical topic in obstetrics. We're going to talk about prophylactic antibiotics for PPROM, specifically in that crucial window between 24 and 34 weeks. As you know, this is a scenario where the stakes are just incredibly high for both mother and baby. So, let's unpack the evidence together. Okay, so just to make sure we're all on the same page, when we say PPROM, preterm pre-labor rupture of membranes, we're talking about the membranes rupturing before labor starts and before that 37-week mark. The moment this happens, it's like a clock starts ticking. The risk for some pretty significant perinatal complications goes way up. And the big one, the one we're really focused on today, is infection. That's really the core of the problem we're trying to solve. So here's how we're going to break this down. We'll start with the PPROM conundrum itself. Then we'll get into the case for prophylaxis. We'll look at the clinical protocol in action, talk about some important limitations and the role of shared decisions, and finally, we'll do a quick knowledge assessment to lock in the key points. All right, Section 1, the PPROM conundrum. And it really is a conundrum. We're talking about understanding the clinical stakes here. Once those protective membranes are gone, that barrier is breached. The risk of a really dangerous intrauterine or neonatal infection just skyrockets. And that, right there, is the central clinical challenge. So, faced with that risk, what's our move? Well, that brings us right to Section 2, the case for prophylaxis. Let's really dig into the evidence for this intervention. Is it the right tool for the job? Okay, so what does the evidence show? There are some pretty well-established benefits. First and foremost, we see a decreased rate of neonatal infections. That's a huge win, right? We also see a slight reduction in major cerebral abnormalities on ultrasound, which is definitely not insignificant. But here's a really crucial one. Antibiotics can extend the latency period. We're talking about buying precious time to get those corticosteroids on board to help with fetal lung maturation. That window can be a complete game changer. But, and this is a big but, it's not a silver bullet. You have to look at the whole picture. For all those benefits we just talked about, there are some really clear limitations. Look at this. Antibiotics do not reduce overall perinatal mortality. They don't stop the baby from being born before 37 weeks. They don't change C-section rates or other key maternal outcomes. So let's be crystal clear. We're managing a complication here, infection. We're not fixing the PPROM itself. It's a critical distinction to make. Okay, so we've weighed the pros and cons. Now let's get practical. How do we actually put this into practice? This is Section 3, the clinical protocol in action. We're talking about the recommended regimen and how to apply it. So the go-to regimen is pretty straightforward. It's all about amoxicillin. Step 1, you prescribe it. Step 2, it's 500 milligrams, given orally. Step 3, that's 3 times a day. And step 4, you continue that for a full 7-day course. Pretty simple, right? And that simplicity is key for consistent application across the board. All right, let's make this real. Imagine this scenario. A patient walks in, 29 weeks gestation, and you've confirmed PPROM. The question is, what's our move? How do we manage this case? Okay, so for our patient, we'd go ahead and start the amoxicillin 500 mg TID for 7 days. Now, why are we doing this? We're primarily targeting group B strep, but also covering other likely pathogens. But we don't just set it and forget it. What are our off-ramps? Well, we can stop the antibiotics if a GBS test comes back negative, or obviously if she delivers before that 7-day course is up. And an important side note here, we don't typically do a routine GBS culture for PPROM before 34 weeks. It's just not advised. This brings us to Section 4, and this is where things get really nuanced. We're talking about limitations and shared decisions. It's all about that delicate dance of balancing the hard evidence, the potential risks, and, crucially, the patient's own autonomy. And this, right here, is the core dilemma. It's a classic clinical trade-off. On one side of the scale, you have a very real, tangible benefit. You're targeting pathogens like GBS and E. coli to cut down a neonatal infection. But on the other side, you've got this huge, looming systemic risk, the development of broad antibiotic resistance. Every single time we write this prescription, we are trying to find the right balance between these two forces. So a natural question comes up, right? You might be thinking, well, what about other antibiotics? Are we missing a trick? Specifically, Do things like macrolides or maybe combination therapies give us a better outcome than just sticking with a simple penicillin group drug? And the evidence, as it stands today, gives us a pretty clear answer. No. There's just no established proof that macrolides or combo therapies are any better for this specific indication. And that really brings us back to a core principle, doesn't it? Prudent prescription is paramount. Stick to what the evidence supports. I think this statement really captures the essence of what we're talking about today. It's a powerful one. Prophylactic antibiotics and PPROM offer a powerful shield against neonatal infection, yet they are not a panacea for perinatal mortality, demanding a delicate balance of evidence and patient-centered judgment. That really says it all, doesn't it? And because of that delicate balance, this next part is absolutely non-negotiable. Shared decision-making isn't just a nice-to-have, it's a clinical mandate. This means we have to sit down with our patients. We have to thoroughly explain the potential upsides. We have to be brutally honest about the drawbacks and what this treatment can't do. And most importantly, we have to listen, integrate their values and preferences, and build that therapeutic plan together. Okay, time to consolidate all this. Let's move to our final section, a quick knowledge assessment, just to make sure these key clinical concepts are locked in. Ready? All right, question 1. What is a primary benefit of giving prophylactic antibiotics in PPROM between 24 and 34 weeks? Is it A, reduced maternal mortality, B, preventing preterm birth, C, a decrease in neonatal infection rates, or D, eliminating the need for corticosteroids? And the answer is C, a decrease in neonatal infection rates. This is really the main reason we do it. Neonatal sepsis is such a devastating complication in these tiny preemies, so this is a truly significant benefit. Okay, question number 2. What's the recommended antibiotic regimen we discussed for prophylaxis in PPROM? Take a look at your options. The correct answer here is B, amoxicillin 500 milligrams orally 3 times a day for 7 days. Yep, that's the standard evidence-based protocol we follow. And for our last question, let's flip it around. Pay close attention to the word not. Which of these is not a reported effect of prophylactic antibiotics in PPROM? And the answer is D, a significant reduction in maternal sepsis. This is a key point about the limitations. While we see neonatal benefits, the data just doesn't show a significant impact on major maternal outcomes, like sepsis, with this particular intervention. So, I'll leave you with this final provocative question to take back to your clinical practice. In this era of ever-rising antibiotic resistance, how do we, as clinicians, continually reevaluate and redraw that fine line between necessary, life-saving prophylaxis and cautious, responsible stewardship? Something for us all to think about.